Howdy everybody, welcome back to MSK. My name is Jonathan and today we are continuing to go over another pathology of the brachial plexus, Klumpke palsy. Let's hop into it. Starting with the pathophysiology, Klumpke palsy is usually defined as the injury to the lower trunk, which is traditionally C8 and T1. Alright, so let's take a closer look at the brachial plexus and see how an injury here at the inferior or the lower trunk will affect the downstream nerves. So if we follow our injury down the medial cord, we will see that the ulnar nerve, which shares its roots C8 and T1, will be primarily affected. In addition, the median nerve gets much of its innervation from C8, T1, and we may also see deficits in something like the medial pectoral nerve. By now you recognize that the median nerve is not just innervated from C8, T1, but from all of the nerve roots of the brachial plexus. But recall that nerve roots' contribution to the final nerve is not uniform. And so in the case of lower trunk injury, in the case of Klumpke palsy, we see motor deficits in the hand of muscles that we know to be innervated by the median nerve. So to reiterate, we will predominantly affect the ulnar and median nerve in the case of lower trunk injury. All right, let's move on and talk about causes. So similar to Erb palsy, the cause of this injury is likely to be dependent on the age of your patient. So in infants, it's almost always going to be from a birth injury, specifically upward traction from delivery. So if there's an excessive amount of abduction of the arm, pulling it up and behind the head, then that can stretch the nerve and cause damage. This excessive upward traction and hyperabduction can also be caused during shoulder dystocia. This is an obstetric emergency in which the baby's shoulder gets caught behind the mother's pubic symphysis. The different maneuvers and movements trying to free the baby from this position can cause the damage and lead to Klumpke palsy. Importantly, this is more likely to cause Erb palsy. So just because a question mentions shoulder dystocia doesn't mean we can definitively assume that it is Erb palsy or Klumpke palsy. We'll have to look at the rest of the clues in the question to figure out what's going wrong with the patient. In an adult, this injury is more likely to be from a traumatic injury or chronic compression. Similar to the birth injury, the types of trauma that will lead to Klumpke palsy are likely to be hyperabduction of the arm. And so an example might be somebody falling out of a tree and trying to catch a branch in order to break their fall. So they'll reach out and grab that branch, but continue to fall past it. And as they do, that branch will pull their arm and hyperabduct it and extend it behind their head and cause an injury to the lower trunk. The injury also does not need to be from trauma. There can be chronic compression through a pancreas tumor, which is a tumor of the lung, or a cervical rib. So normally you have ribs coming out of your thoracic vertebrae starting at T1, but about 1%, maybe a little less of the population actually has a cervical rib coming out of C7. And though it's usually asymptomatic and people don't know until they have an x-ray, it can compress nearby structures. In the event that the cervical rib does compress or damage the lower trunk, then we can have Klumpke palsy. If it also is compressing or damaging other structures like the subclavian vein or the subclavian artery, then we can have something known as thoracic outlet syndrome, which will have its own video. Klumpke palsy and thoracic outlet syndrome have overlapping presentation, and so the important distinction between them is that Klumpke palsy is generally pretty specific to just nerve damage. Because thoracic outlet syndrome can also compress the vessels of the arm, we see additional signs like pulselessness or swelling of the affected arm. So let's move on and talk about the details of presentation in Klumpke palsy. So in contrast to Erb palsy, which affected almost the entirety of the arm, with the shoulder and the elbow and the wrist all affected, Klumpke palsy will be mostly isolated to motor deficits in the hand. And this is because the intrinsic muscles of the hand are innervated by the ulnar and median nerve, which are affected by that lower trunk injury. In the case that we lose the strength of those intrinsic muscles of the hand, we are left with flexion at the proximal and distal interphalangeal joints and extension at the metacarpal phalangeal joints, leaving us with a total claw hand, as we can see in this picture down here. So if we think about the intrinsic muscles of the hand, that is including the thenar compartment, the hypothenar compartment, adductor pollicis brevis, the palmar and dorsal interossei muscles, and very importantly, the lumbricals. And now these lumbricals are going to help us out because they are dual innervated, with the medial side being innervated by the ulnar nerve and the lateral side being innervated by the median nerve. And that's very helpful for us in helping to determine where the lesion in this patient most likely is based on their presentation. When there's ulnar nerve damage, we see that the lumbricals on the medial side are not working well. When there's median nerve damage, we see that the lateral lumbricals are not working well. But in Klumpke palsy, because it's on that lower trunk and it's higher up in the brachial plexus, we see that all of the lumbricals are affected. And so we see total claw hand. And that's one way we can help distinguish this between other nerve pathologies. Additionally, there's reduced grasp reflex in infants. So in an infant, if you place something in the palm of their hand, they will instinctively close their fingers and grasp that object. But obviously, if the affected muscles of the hand that are contributing to that grip are reduced, then the infant will not have that same strength or speed of reflex on the affected side. We are also going to see a decrease in sensation of the C8 and T1 dermatomes, which will be the medial forearm and medial two fingers. Additionally, a patient with Klumpke palsy may also have Horner syndrome, which is a triad of miosis, excessive contraction of the pupil, ptosis, drooping of the eyelid, and anhidrosis, which is a lack of the ability to sweat. And so you may be thinking that this is kind of an oddball. All of a sudden we're talking about eyelids when before we were just talking about muscles of the hand. But the relationship between Horner syndrome and Klumpke palsy is not that lower injury leads to Horner syndrome, but rather that they often have the same cause. A Pancoast tumor and cervical rib can lead to Klumpke palsy and also to Horner syndrome. This is important to note because questions will often ask you not just about what a patient has, but what they could have or what they could have a risk for. So if a question describes a patient with Klumpke palsy and suggests that it may be from a Pancoast tumor or a cervical rib, you should be keeping in your mind that Horner syndrome is an additional possible finding in this patient. And lastly, we will go over the treatment of Klumpke palsy. Similar to palsy, splinting will be a part of the treatment process, and so we can splint the affected hand for proper alignment. So in order to counteract the claw hand, the fingers may be kept in extension. Additionally, physical therapy will be necessary to strengthen the weakened muscles, and if very severe, surgery will be needed. And it is always worth mentioning that the most fundamental way of treating something where you understand the underlying cause is to address that underlying cause. So in the event that we have Klumpke palsy from a Pancoast tumor or a cervical rib, then surgery to remove that underlying cause will be the primary objective of treatment. All right, let's do a recap and then we'll do a short practice question together. Klumpke palsy is defined as injury to the lower trunk, which is classically defined as C8 and T1 and will affect the ulnar and median nerve. The cause in infants is traditionally upward traction from a birth injury, and the cause in adults can either be from trauma or from compression of a structure like a Pancoast tumor or a cervical rib. The presentation of Klumpke palsy will be total claw hand, which will be extension at the metacarpal phalangeal joints and flexion at the proximal and distal interphalangeal joints. There will be a reduced grasp reflex in infants from the weakened hand muscles and a decrease in sensation of the C8 and T1 dermatomes on the medial side of the hand and arm. Important to keep in mind, if the cause of that Klumpke palsy was a Pancoast tumor or cervical rib, Horner syndrome may also be an additional finding in that patient. And treatment for Klumpke palsy will include splinting of the hand, physical therapy, and surgery to either fix the nerve or address the underlying cause. A practice question might sound something like this. A 14-year-old male presents to your clinic with shooting right arm pain after an incident in the bouncy house. The patient reports that his hand was caught on the side netting with his arms raised when attempting a flip. Vital signs are within normal limits. On physical exam, you notice that the patient's proximal and distal interphalangeal joints are flexed, but there's extension at the metacarpal phalangeal joint. The two questions I have for you is what area of the affected arm are we most likely to see reduced sensation? And is this patient at an increased risk for having Horner syndrome? So at this birthday party celebration gone wrong, the patient describes a traumatic incident in which there was hyperabduction of the arm, as their arm was raised when it was caught on the side of the net. Additionally, the physical exam shows total claw hand, and so we suspect lower trunk injury from trauma. So the area of the affected arm with reduced sensation will be the medial arm and medial two fingers, and because this patient presents with an injury to the lower trunk from trauma and not from compression from a cervical rib or Pancoast tumor, we wouldn't consider this patient to be at an increased risk for Horner syndrome, especially considering their young age. Alright guys, that's everything from me. Thanks for watching, good luck studying, and I'll see you next time.